Clinical case study by Ayesha, Ellaura, Bott and Sophie Chadwick. 78-year-old Patrick has worsening COPD and left-sided heart failure. He has history of smoking for a total of 40 years and quit at the age of 60. Patrick has also suffered a myocardial infarction on the branch of his left coronary artery at 68 years old. He is fatigued and coughs regularly and suffers from dyspnea. His legs are swollen from the knee down and ambulates slowly. His current observations and body size measurements are blood pressure 135 over 85 millimeters of mercury, heart rate is 155 beats per minute, weight is 95 kilograms, height is 180 centimeters, and waist circumference is 104, which is a BMI of 29.3. A fasting blood test was conducted on Patrick, with the results being discussed further on in the presentation. Patrick suffers from consistent coughing, dyspnea and COPD. It is very likely that Patrick's extensive history of smoking is the base underlying cause of his respiratory conditions, with other aspects of his medical history and lifestyle also heavily influencing and exacerbating these symptoms. Patrick smoked for 40 years of his adult life and quit by the age of 60. Even after cessation, the damage and inflammation of smoking is irreversible. Due to this, it is a causative factor of several lung conditions, including pulmonary fibrosis, emphysema, and chronic bronchitis, which results in symptoms such as dyspnea and coughing. Studies have shown a distinct connection between obesity and worsening lung conditions due to decreased lung volumes of FEV, FVC, FRC, and ERV. Although Patrick is not obese, he is considered overweight, which would contribute to his symptoms. Furthermore, there is evidence that shows that physical exercise has many benefits to respiratory health, including an anti-inflammatory effect, reduction of oxidative stress, and also of respiratory tract infections. If Patrick lived a sedentary lifestyle, this would have exacerbated his respiratory symptoms, as exercise has the capability to counteract some of the harmful effects that smoking causes. In relation to Patrick's increased heart rate, factors contributing to this include hypertension. His high blood pressure causes stress on the arteries of the heart, contributing to the increase in heart rate to pump oxygen-rich blood around the body. His already diagnosed left-sided heart failure causes cellular changes like hypertrophy. Collagen deposits between cells causes decrease in contractility. As a consequence, an accumulation of blood pools in the left ventricle, which means not enough blood is being pumped into the systemic circulation, causing activation of the RAS system and peripheral edema. As for the pulmonary circulation, a backlog of blood in the lungs causes pulmonary edema. As for his weight, in overweight individuals, the cardiac structure and function of the heart changes as a consequence of an increase in total plasma and blood volume, with subsequent increase in left ventricle filling and cardiac output, causing left ventricular hypertrophy, which also links to his left-sided heart failure. In terms of his already diagnosed COPD, a decrease in oxygen levels and increase in carbon dioxide levels, resulting in an increase of pH of the blood, causes ventilation mismatch, which in turn contributes to acidic hydrogen ions not being buffered sufficiently. Chemoreceptors in the aortic arc detect this and stimulate the cardiac-excitatory sensor to increase the heart rate to keep circulation moving. Chronic obstructive pulmonary disease, COPD, is where the air sacs or alveoli of the lungs become persistently inflamed or damaged, causing narrowing of airways and resulting in dyspnea. It is a term given to a collective of lung conditions including chronic asthma, chronic bronchitis, and emphysema. COPD is an irreversible disease. However, management and lifestyle therapies have been developed to improve quality of life. The main symptoms which occur with COPD are excessive coughing and dyspnea. The cause of Patrick's diagnosis of COPD is most likely due to his history of smoking. Research shows that smoking is the most common causative risk factor of COPD. Although Patrick ceased smoking over 18 years ago, studies conducted on smokers found that even after cessation of smoking, inflammation within the airways is ongoing, thereby increasing the severity of his COPD. Left-sided heart failure or left ventricular failure is where the left chamber, specifically the left ventricle, is unable to sufficiently pump blood around the body, thereby reducing the amount of oxygen-rich blood being delivered to the organs. As the left side of the heart is the strongest, when it begins to fail, it must work harder to pump the same amount of blood. Left-sided heart failure often results in hypertrophy in the cardiac muscle cells in the left side and pulmonary edema. Studies have found that heart failure, specifically left ventricle failure, is a frequent complication of an MI, as when an artery gets blocked, the lack of oxygen-rich blood and nutrients damages the heart muscle. This weakens the heart by reducing contractility and ability to pump blood sufficiently. Common symptoms which occur with left-sided heart failure include dyspnea, coughing, wheezing, increased heart rate, and edema. The modifiable risk factors of left-sided heart failure are smoking, sedentary lifestyle, and dyslipidemia. As heart failure is irreversible, management therapies such as adequate control of blood pressure or other risk factors are available to help improve symptoms and reduce mortality. As Patrick has suffered an MI branching from his left coronary artery, it is the most causative factor of left-sided heart failure due to its pathophysiology. COPD and left-sided heart failure are often associated together as they have similar pathogenesis. In a clinical setting, it is common to find patients diagnosed with both conditions, as studies have shown that the conditions influence each other but are not directly related. COPD can cause a decrease in O2 levels in the blood, which can exacerbate the strain on a person's heart, resulting in worsening of left-sided heart failure. Along with this, fluid backed into the lungs from left-sided heart failure can also exacerbate COPD, causing dyspnea. Several risk factors such as smoking, age, and systemic inflammation are common between both conditions. Given Patrick's history and his current symptoms, it suggests that COPD was likely the first condition developed due to his history of smoking. The development of left-sided heart failure was likely due to Patrick suffering a MI to his left coronary artery, as studies have found it to be a common complication. However, as previously mentioned, COPD can influence the severity of left-sided heart failure as they share similar risk factors.
The right side of the heart is responsible for pumping deoxygenated blood from the body back into the lungs to be reoxygenated. Right-sided heart failure, or cor pulmonale, is usually a complication of left-sided heart failure. When the left side of the heart fails, the pressure buildup causes a backflow of blood into the lungs. Similarly, when the right side fails, excessive pressure and strain causes the blood to backflow into the body's veins. A common complication of right-sided heart failure is affecting the kidney's ability of controlling sodium and water retention. This disruption usually leads to edema of a person's legs, ankles, and lungs. However, it has been known to affect the whole body. COPD causes pulmonary edema, resulting in symptoms of dyspnea and pulmonary hypertension. These factors mostly result from low O2 levels in the lungs and surrounding vessels. The resulting excessive strain on the right side of the heart contributes to right-sided heart failure. Patrick's diagnosis of left-sided heart failure and COPD, coupled with his medical history and specifically his smoking, increases his chances of developing right-sided heart failure exponentially, causing both congestive heart failure and cor pulmonale. Patrick's blood test results show that he has electrolyte imbalances including hypernatremia, hyperkalemia, and hypocalcemia. Electrolyte imbalances are often observed in the elderly due to the prevalence of decreased renal function. Furthermore, there is evidence that suggests that renal failure is an anticipated comorbidity of patients with COPD, which could be a contributing factor as to why Patrick is experiencing these electrolyte imbalances. Other contributing factors to hypernatremia could be an imbalance of fluids, including an inadequate intake of water. Not to mention that hyperkalemia is often the result of pharmacological impacts, and this could be occurring due to medication Patrick is taking for his left-sided heart failure and COPD. Finally, hypocalcemia often occurs in the elderly due to inactivity and poor absorption of calcium. An imbalance of electrolytes can have a significant effect on neurological function. For example, dehydration of the cells from hypernatremia can result in neurological impairment. Additionally, Patrick's blood tests show that he has metabolic syndrome. The combination of his abdominal obesity, elevated fasting levels of triglycerides and glucose, as well as a low HDL, and his blood pressure are all indications of this. The main contributing factors to developing these results and therefore metabolic syndrome include poor diet, a sedentary lifestyle, central visceral adiposity, smoking, and in the case of raised triglycerides, increased age. As Patrick is considered overweight, has a history of smoking, is elderly, and has a large waist circumference, it can be assumed these factors contributed to the development of this. The individual blood results and therefore metabolic syndrome overall have the potential to significantly impact upon neurological function as well. High LDL and low HDL, for example, are risk factors for the development of atherosclerosis and therefore dementia and stroke, as well as Parkinson's and Huntington's disease. An additional blood test result of Patrick's that would show an abnormally high result is the hormone brain natriuretic peptide, as BNP is used as a diagnostic marker for heart failure. BNP is secreted from the left ventricular cardiomyocytes in response to pressure changes within the ventricles, as well as excessive and sustained stretching of atrial muscle cells. The physiological effects of BNP are to decrease the strain upon the heart through mechanisms such as inhibiting the RAS system, increasing natriuresis, and vasodilation. As BNP is only released when there is significant stress upon the heart, it can be assumed that there would be a high level present in Patrick's blood due to his left-sided heart failure.